Hello, my name is Hope Frost, and on behalf of SBK Healthcare and Diabetes National Networking Forums, I'm delighted to welcome you to the recording of this webinar. This session is one of a four-part series, and today we will focus on an introduction to continuous glucose monitoring for primary care. You'll be led through today's session with speakers Sarah Davies, Su Down, and Jane Diggle. Do make sure you check out our website and watch the following 3 webinars too. They will focus on identifying eligible patients for CGM, starting patients on CGM, and an introduction to data interpretation. I would like to thank Abbott's Diabetes Care Division for supporting these important educational webinars. We also run in-person conferences and other online training, for which the details can be found on our website.
Thanks very much, Hope, and thank you very much to everybody for joining us this afternoon. Brilliant to have so many people logging on. I'm sure you've had a busy morning in clinic or whatever you've been doing, so brilliant to be having you joining us, be it live or, of course, on the catch-up version as well, which will be available following today. So yeah, my name's Sarah Davies. I am a GP with a special interest in diabetes from Cardiff, but very much general primary care. So I don't count myself an expert in diabetes and technology. This is something we're all learning about together. And I hope that's really the message that you're going to get throughout this series of webinars, which I'm really excited to be part of. Now, I have the very easy job today, folks, don't I? Because I'm chairing the session. Thankfully, we are joined by 2 fantastic speakers, my friends and colleagues today. So I'm going to ask them to say a quick hello, actually, so they can show themselves. Lovely. So first of all, we are joined by Su Down, diabetes nurse consultant and clinical lead from Somerset. Good afternoon, Sue.
Hello, Sarah. How are you?
Yes, very well, thank you. Looking forward to today's webinar very much. Sue is a fount of all knowledge on diabetes, folks. I sort of am renowned for asking her questions on a very frequent basis, and do you know what? She always knows the answer. So hugely experienced, Sue. We're looking forward to you joining us. Thank you. Yeah. We're also joined by Jane Diggle, again, friend and colleague, specialist diabetes nurse practitioner, College Lane Surgery, Ackworth. Good afternoon, Jane.
Good afternoon, Sarah and Sue. So I'm going from the other end of the spectrum, I have to say, Sarah, because 20 years or so as a practice nurse, that's where I developed my interest in diabetes. But yeah, Sue's the real expert, but I'm coming to it from a more generalist background, I would say.
Fantastic. And I think we need all that. And I know we've got a wide range of different people watching today in terms of people's experience so far with continuous glucose monitoring. And for some people, it'll be completely new to them. But this is something which we are learning together. And I hope you're going to find this series of webinars and indeed our following face-to-face course really helpful indeed. So we'll take the next slide, please. Here are our disclosures. And the next one, please. The whole series is sponsored by Abbott, and of course, we're very grateful for that sponsorship. Next one, please. Lovely. So as Hope was saying, this is actually the first in a 4-part webinar series. So over the next 4 weeks, we have got these 4 webinars coming up. So today is very much an introduction to continuous glucose monitoring. We're going to introduce the concept. I'll show you the agenda in a moment anyway. Next week, we're talking about identifying eligible individuals. So who might be appropriate? How do we go about finding these people that might benefit, particularly in the primary care setting? The following week, we go to an evening session, so just make sure you've got a record of the timings there. And we're talking about initiation of continuous glucose monitoring there. How do we get people started in the easiest way, both for the person living with diabetes, but also for us as healthcare professionals as well. And then the 4th in the series, on the 20th of May, again, an evening session, that one, folks, starting to think about interpreting the data from continuous glucose monitoring. Can feel sometimes a bit overwhelming, perhaps something that, well, we haven't got time or the ability to do in primary care. I would argue that, yeah, absolutely we have. It can be done very simply, but of course we need to be able to understand that data to be able to give our person living with diabetes that great feedback so that we can really make safe choices alongside that person for their treatment. So that'll be a nice introduction to data interpretation in the final part of the webinar series. And then if we go to the next slide, please. following the 4 webinars, and as I mentioned, you will be able to watch them on catch up if you can't attend one of them live. You've then got the opportunity to come along to a complimentary face-to-face course, which is taking place in various different locations across England, trying to kind of spread the geography across England at least. So there should be one hopefully within a reasonable distance from most people. And at that face-to-face course, there'll be at least 2 out of 3 of Sue, Jane and myself, plus guest speakers as well. And we'll be diving into the data interpretation that bit more. So we'll be looking at loads of case studies. So it becomes almost second nature in terms of looking at data from continuous glucose monitors and being able to safely interpret it. So if you haven't booked onto the face-to-face yet, do have a look at those dates and locations and pop onto the website to get yourself booked onto a place. We're looking forward to our roadshow, ladies, aren't we? Our travelling roadshow. Okay, yeah, absolutely. Oh, sorry, here's the agenda for what the roadshows will look like in the face-to-face setting. So you can see a bit of time for travelling. So it's a 10:30 start, registration from 10 o'clock, and then finishing at 3:15. So hopefully time for your travel. And again, we'll look at your basic knowledge, see where we are, that we're all up to scratch on what we understand so far, start to get into grips with that data interpretation, particularly around the fundamentals of what you can see on the right there, the AGP or ambulatory glucose profile. And as I said, loads of case studies that we'll be studying throughout that session. Next slide, please. So today is the first in our webinar series, very much an introduction to continuous glucose monitoring. Next one, please. The plan is to talk about FreeStyle Libre. Why is it important? What are the potential benefits for people who are on insulin treatment? We're going to very briefly look at the basic system. How does it work? What is this technology? And a little think about blood glucose monitoring, so our kind of old-fashioned capillary glucose monitoring approach versus a continuous glucose monitor. What is the difference? What added value can a CGM give us? We'll talk about the criteria for FreeStyle Libre, and we're going to talk about the triangle of diabetes care. What are we trying to achieve? Improving glycemic control, avoiding hypoglycemia, and avoiding too much in the way of glucose variability as well. We'll have a little look at the evidence of benefit. We're starting to gain more and more evidence now, particularly people living with type 2 diabetes. And we'll also touch on time in range. Definitely a phrase we're starting to hear more and more, I think, in primary and secondary care, and something we need to be familiar with in terms of how it fits in to diabetes management. Next one, please. So very briefly, in terms of scene setting, before I hand over to Jane, who's going to kind of kick us off with the slides for real. We know that glycemic control is important in the management of type 2 diabetes. We've known that for many years. We know that tighter glycemic control reduces the risk of those complications of diabetes, be it macrovascular complications, heart attack, strokes, microvascular complications, retinopathy, amputation, peripheral vascular issues. We also know that people living with diabetes are much more prone to be admitted to hospital, to have long and recurrent admissions, particularly if they have complications related to their diabetes and higher HbA1cs over prolonged periods of time. So we want to support people to achieve their individualized glycemic targets. But we know that's really challenging to do for many different reasons, of course. And we're increasingly, I think, in primary care, looking after more complex patients living with diabetes, with multiple long-term conditions, frailty, with polypharmacy perhaps. And there are a lot of reasons why it's difficult to achieve glycemic control. I don't know about you, but I know that I'm seeing a lot of people with higher HbA1cs at the moment, sometimes in triple figures, and it can be difficult to reach targets. And we know, in fact, that we often don't reach those targets. So 66% of people, and this is data from the National Diabetes Audit a couple of years ago, 66% of people with type 1 diabetes not meeting that general recognised target of an HbA1c of less than 58 millimoles per mole, 36% of people with type 2 not reaching that target. Of course, 58 won't be an appropriate target for some people living with diabetes, but for most people, it's around the right neck of the woods. So how can we use perhaps technology, including continuous glucose monitoring, to maybe improve things, to try and achieve or help our patients to achieve those HbA1c targets in a safe way, of course, avoiding things like hypoglycemia. And that's very much what we're going to explore today. So I'm going to hand over to Jane now after my brief introduction, and she's going to kick us off with the slides for real. Over to you, Jane. Oh, don't forget, everyone, type your questions. We want all of your questions. I'm going to put them all to our ladies today. I may try and answer a couple myself if I able to do so, but we're definitely going to be putting them to our speakers. So do pop your questions into the Q&A box, and I'll have plenty of time at the end to put them to our speakers. Over to you, Jane.
So thank you, Sarah. So obviously improving HbA1c in a person with diabetes is important, and of course that's the reason why we have HbA1c targets. We know, as Sarah has said, that reducing the HbA1c and achieving the recommended personalised target reduces a person's risk of the diabetes-related complications. And I think we've tended to regard HbA1c as our absolute gold standard measure of glycemic control. But it can, in isolation, be misleading, and it may not be a reliable predictor of glucose control. So in this slide, you can see two people, and they are sharing exactly the same HbA1c, which is 61 millimoles per mole. But if we actually look at what's happening to their glucose levels throughout the day, which we refer to as their glucose profile, if you look at it throughout the day and across many days, you can see that the two graphs are very different despite exactly the same HbA1c. So for the person on the left of the screen, if you look at that thin dark blue line, which is what we call the median line, so that's the middle value in a set of data, you can see it's fairly flat and it's mostly within that red dotted band, which is the target range. So for the blue, you can also see around that median line, you've got blue shaded area and also a light blue shaded area. And that's actually giving you the variability. So it's giving you kind of the other readings that are appearing at that particular time of day. And again, in the person on the left, it's fairly narrow. So those blue and grey bands are fairly narrow. So there is some variation from day to day and at different times of the day, but it isn't hugely variable. Compared to the person on the right, even that thin blue median line has lots and lots of peaks and troughs. So the blood glucose level is going up and down much more. You're getting these swings where it's moving outside of that target band. And you can see those shaded areas are also much wider than the person on the left, which is telling us that their glucose levels are really quite variable. But this is something that you're not going to be aware of from the HbA1c, because obviously that's just giving us an average measure over the 2 to 3 month period leading up to that. And so, of course, this is why if people are on an agent which can, particularly those agents which can be associated with low blood sugar levels, so sulfonylureas and insulin, why we ask them to perform self-monitoring of blood glucose. So let's look at what that actually tells us in the next slide. So you can see that a finger prick capillary glucose test is going to tell us at that moment in time what the blood glucose level is. So it's very much a snapshot. It doesn't tell us if it's rising or if it's falling or how rapidly it's going to do that. So on the left, we have actually seven finger prick tests, which I would say in the course of a day is pretty impressive. But what we don't know is what is going on between those 7 snapshots. We don't know if the levels are on their way up, if they're on their way down. Compare that to the graph on the right side. So continuous glucose monitoring is really filling those gaps between those dots. It's filling the gaps between the snapshots, and what we're seeing is minute by minute what's happening to the glucose levels. So let's move to the next slide. So of course we encourage people to do frequent finger prick testing, sometimes, you know, as much as 7 or 8 times a day. And there is good evidence to show that by increasing the frequency of that monitoring, you get improvements in HbA1c and glucose management. But I think it's important to bear in mind that it has its limitations. I think, you know, there's the inconvenience, the level of motivation and commitment that is needed. And I think that can have quite a negative impact on quality of life and also perhaps contributing to feelings of stigma particularly where a person may have to do this testing in a public place. It can contribute to feelings of anxiety, and it can be a real struggle. And in fact, what you can see here is around 25 to 30% of people experience anxiety around fingerprint testing. And in fact, up to a quarter of people will try to avoid doing it because they don't like it. And I think if we were to put ourselves in that position, I know myself, I would really hate to have to do this. So if we move on to the next slide. So frequent testing, proven benefits. And you can see on the graph, as the number of glucose tests per day increase, the mean HbA1c reduces. And you can see that in people with type 2 diabetes on insulin, which is the light blue line, and also those with type 1 diabetes, which is the darker blue line. But I think here's the big but here. Many people in reality struggle to adhere to these self-monitoring recommendations. And I'm sure you're very well aware of that when you see people in clinical practice. This is a study which shows that 2/3 of people fail to adhere to the self-monitoring recommendations that we're giving. And in fact, it's interesting because people with type 2 diabetes are 4 times more likely not to adhere to that compared to people with type 1 diabetes, which I think is quite interesting. So if we move on to the next slide, I don't believe actually it's an exaggeration to say that continuous glucose monitoring has the potential to completely transform a person's life. And that's something that people are telling me. And I don't think it's just the act of glucose testing. The information it provides is hugely different. So if you take a look at that picture of blood glucose diary on the left, it will be very familiar to you. That is, if a person actually brings it along to the consultation, and that's obviously not always the case. And you can see that that diary is perhaps more complete than many that you might see, but nevertheless, there are still quite a few gaps. You know, it's a massive undertaking and a commitment. And I totally understand that people might struggle to do frequent finger prick testing, even in the lead up to a consultation. But as you can see, the amount of data that's supplied is really very limited compared to what you would get from continuous glucose monitoring systems, which are really providing readings that are transmitted minute by minute for the lifespan of the sensor. And in this case, it would be 14 days. So you can see the number of readings that you're getting in a day. So if we go on to the next slide, it got me thinking about an analogy, if you like, and I thought it's a little bit like driving to somewhere that you don't know. So you kind of know where you want to be, but you don't really know how to get there. So you have to make some best guesses. You maybe would have a map that you can refer to, although it's not easy to get hold of those these days. You may be looking for signposts. Compare that to a sat nav. I mean, how would we survive these days without a sat nav? It's almost the automatic thing we now do. I think interpreting what is going on from a blood glucose diary is really difficult. And I totally understand that technology can be a little bit scary to begin with. I think it can be scary for the person living with diabetes, but also, of course, for us, particularly, I think, those of us working in primary care settings where we may not be specialists in diabetes. But I would say that in the long term, it makes our lives easier. And in the long term, it's much easier to interpret data when you've got a much more comprehensive picture to look at. So if we move on to the next slide, the purpose of this webinar series, we are going to be focusing on one particular CGM system, and that is FreeStyle Libre 2. So if I just go through a little bit about the system, it comprises a small sensor, which you can actually see there on the screen, which is applied to the back of the arm and stays in place for 14 days. Sensor 2 Plus is just been launched, and that does have a slight extension on that, so that will be 15 days. So the sensor can be paired to a mobile device using the Libre Link app, or it may be used with a reader. So the sensor must be periodically scanned if the reader is being used in order to transmit the data, but that's no longer the case where a mobile phone device is used. And what you see on either of those screens is the current glucose level. And also you see an arrow on there, which is showing you the speed at which that glucose level is changing, whether it's going upward or downward or stable. And we're going to talk a lot more about that in this series of webinars. So if we move on to the next slide. So if a person doesn't have a compatible smartphone, and it's very easy to check to see if their phone is compatible, they will need to use a reader, and those are available directly from Abbott. So the reader needs to be paired to a new sensor and scanned every 8 hours. But if a person doesn't scan, it's ideally they should be scanning when they're using a reader, and if you can scan as much as possible, that's going to be beneficial. Probably around 6 scans per day will enhance the data that's provided. And we refer to this way of using continuous glucose monitoring as intermittently scanned CGM. As I said, there is now no longer a requirement to scan if a person's using their mobile smart device, apart from the initial scan when they set up and pair to a new sensor. And so what's happening with their mobile device, providing they keep Bluetooth switched on, is that the sensor will be transmitting the glucose data continuously, providing that the device is within 6 meters without obstruction of the sensor. So when the device is viewed or scanned, it shows the current glucose reading on the screen. It shows you the trend arrow, which I mentioned, and it also shows a graph showing the latest 8 hours of glucose data. So if we just move on now to the next slide. So both real-time and intermittently scanned CGM are methods of measuring glucose level via interstitial fluid, and we'll come back to that, what we mean by that shortly. So intermittently scanned CGM was sometimes referred to as flash glucose monitoring, and this is when the sensor did have to be scanned in order to retrieve data. But as I said, no longer a requirement if using a smart mobile phone device. So as I briefly mentioned, Abbott have recently launched their Libre 2 Plus sensor, which lasts that little bit longer, so 15 days, and is now compatible with the Omnipod 5 automated insulin delivery system. So we will see that transition over time to the Libre 2 Plus, offers slightly better accuracy, as I said, lasts 15 days, and is licensed from 2 years of age. I think for those of us working in primary care, mostly dealing with people with type 2 diabetes, I don't think there's really going to be much difference for us. So the next slide actually gives you an image of the sensor. So as you can see, it's pretty discreet. It's about the size of a £2 coin. Very easy to apply using the applicator, and that's to the back of the arm. It doesn't need any calibration. It doesn't use a transmitter. It's water resistant. People often ask about this. So it's water resistant down to 3 feet for up to 30 minutes. So fine for swimming, and of course fine for bathing and showering. And as I said, readings are provided every minute. And then the next slide said we'd talk a little bit more about what we're actually measuring. So when the sensor is applied, there is a soft microfilament that is inserted. A needle is used to make the insertion, but the needle doesn't remain in the skin. It's around 5 millimeters under the skin surface, and it's actually sitting in what we call interstitial fluid, which is the fluid that surrounds the cells. So it's important, as you can see on this slide, to note that the filament is not positioned within the blood. So it's not detecting blood glucose, but interstitial glucose. Compared obviously to the finger prick test, which you can see on the left of the screen, which is measuring the glucose within the capillary, so obviously blood glucose. So if we move on to the next slide, the two measures, so blood glucose and interstitial glucose, are closely related, but they are not identical. And I think that's an important thing to talk to people about, because if they were to simultaneously check their finger prick glucose, blood glucose level with what they were seeing on their CGM, they may be slightly different. And the reason for that is the interstitial glucose reading lags a little bit behind a finger prick blood glucose reading. It's about just over 2 minutes. So 2.1 minute for children, a little bit longer, 2.4 minutes for adults. Having said that, if the glucose level is changing very rapidly, the difference between the two can be greater. So if the glucose levels are falling quickly, the glucose readings for the sensor may appear higher than the blood glucose level. And then at the other side of the coin, when the glucose level is rising rapidly, the glucose level from the sensor may appear lower than the blood glucose level. So I think a good way to illustrate this and maybe share this information is on the next slide. So this shows you a train going along a track, quite a steep track. But if we start off on the left side of the screen, the track is flat. So the sort of orange-red carriage at the front is your blood glucose. Now, a few carriages behind that, we have the interstitial glucose levels in yellow. So where the blood glucose levels are stable on the track and it's flat, you can see the levels are going to be very similar. So the interstitial glucose just a minute or two behind the blood glucose. However, as the train starts to move up the track and it gets to that steep incline, so the blood glucose levels are rising, the measurement displayed on the FreeStyle Libre system could be below that on the blood glucose reading that you would get. And then you can see the opposite is happening here. So therefore, when the blood glucose level starts to decrease, the train goes down the track, you can see that the yellow carriage is higher than the blood glucose reading, which is in the kind of orange-red carriage. So hopefully that helps to be able to explain to a person why there may be some differences. I'm going to hand over to Sue now, who's going to take you through a little bit more information.
Thank you, Jane. And I think that's such a good illustration of the change that we see between the two here. And I'm going to carry on and take us through a bit more to say what Sarah pointed out at the beginning. What is it that we're looking for in terms of our diabetes management, but also how CGM can help and some of the evidence base behind that. I think carrying on from everything that Jane has said, yes, we know that there is extensive evidence that the lower the HbA1c, the greater the reduced risk of developing diabetes complications. But we also know and have known for some time that it is just one view of the window, and there's many things that an HbA1c does not tell us. The two other really important things that we have to manage with diabetes control to get the best out for patient outcomes is the absolute avoidance of hypoglycemia. There's so much evidence around fear of hypoglycemia. If people are experiencing repeated hypoglycemia, they will take very evasive action to prevent it happening again, none of which helps us achieve their overall target because they want to drive their glucose higher to avoid this hypoglycemia. And the other thing that we are learning more and more and more is that this glucose variability, now I'm aware that that's a term that's become more familiar to us all in recent years, not something that we massively talked about before. But this is where we have high swings of glucose, below high to low to high to low. And there is evidence now that suggests that this swinging, this variability, can actually increase and is directly linked to the development of complications. So we have to limit variability, and that's variability across the day and day on day on day, variability that appears at the same time every day or could appear at any time from morning to evening. So if I can have the next slide, please. There is growing evidence, some of which I'm going to go through, which really ties all of this together. Everything Jane was explaining about what we see in continuous glucose monitoring and why we are now moving. And I have never seen technology move as quickly in diabetes. And as the girls suggested earlier, I have been in diabetes for many, many years. But I have never seen technology take off so quickly as we have with CGM. And I've never seen it embraced so rapidly by patients. And one of the things that they say is finally their diabetes makes sense. Having this additional knowledge of not just what a glucose is, but where it's going and where it's been, but predominantly where it's heading, allows them, A, to make choices, but B, to understand that some of their actions, some of what they, in terms of meal choices, exercise, everything there, the impact of those actions actually has on their blood glucose. And finally, diabetes makes sense to them. And if it makes sense to the person with diabetes, it is likely that therefore some of that variability and the avoidance of hypos can take place. And that's the information that people get from continuous glucose monitoring. So we do have evidence that the more that they can hold their glucose in that target range, which I'm going to explain more in a minute, but Jane did point out earlier, if they can hold their glucose more in that range, we know that that is linked to improved quality of life because people feel better and feel in control. But also the amazing evidence about reducing the risk of hospital complications from severe hypoglycemia and from DKA. And it's because of this massive reduction seen in these hospitalizations, which actually for all countries around the world has really pushed use of this technology. So if I could have the next slide, please. So this is just a study in the UK, the FLASH study, and this just took 156 people with type 1 diabetes. Their control was pretty much, they had an HbA1c on average above 58, and they were adults, they were above 16, and they were given the FreeStyle Libre 2 system, and they were followed up for 24 weeks to see what happened, just giving them this technology. And you can see here that actually against people who were trying to manage their type 1 diabetes with finger prick monitoring, that they did improve their HbA1c by 0.5%. So that's about 5 millimoles per mole, 5 or 6 millimoles per mole. However, what they did improve is that they spent an additional 136 minutes a day with their glucose in the optimal target range and 43 minutes per day less time with a blood glucose below 3.9, and staggeringly 86 minutes a day less time spent with a glucose above 10. And that's just from having this technology and from visually seeing what was happening with their glucose so that they could then take actions. So the next slide, please. And this relief study is a French study, and this looked at very different things. So this was a complete population-based retrospective analysis of people who had been using FreeStyle Libre 2. And you can see here, particularly for this audience, this wasn't just in type 1 diabetes. This also looked at people with type 2 diabetes using this technology. And the numbers were huge. Obviously, France is a big country. A lot of people had this technology. And so they could retrospectively look at the impact of using the FreeStyle Libre system. And I like this study for several reasons. Firstly, again, it absolutely supported what we have seen in the massive reduction in hospitalization for things like DKA, hypoglycemia, comas, or hyperglycemia if people were admitted for hyperglycemia. And across both type 1 and type 2 diabetes, we see that reduction in hospitalization. And then quite often, if there's a new technology in use, people are very quick to pick it up at the beginning and use it. But does that use and that interpretation and the want to use that data continue, or is it a bit of a fad at the beginning? And the one thing this study did is it followed this group of people, and it could track what had happened over 2 years worth of using the data. So several things. Firstly, that reduction in hospitalization continued. It wasn't just an initial thing, it continued, and that actually we had some slightly better data in some instances over the 2-year period in terms of reduction in these hospitalizations. But what I was really found the most positive thing is that over this 2-year period, the amount of people that continued to actively use their FreeStyle Libre was staggering. So at 1 year, 98% of people who had started to use FreeStyle Libre 2 were still using it. And at 2 years, 88% of people who had access to this technology continued to use it. And as Jane pointed out earlier, we really struggled to get people to engage with capillary blood glucose monitoring. And I can't remember how many times people have asked me over the years, you know, once I've got them somewhere towards target and somewhere towards understanding their diabetes, their first question, can I now stop testing? And it's like, you know, you need to use this data to inform you. And the one thing that we're seeing with continuous glucose monitoring is that people actually continue to use the data because it's meaningful to them. And if it's meaningful to them, they will make choices that leads to improved glycemic control. So the next slide, please. I'm not going to completely bore you with data, but one more smaller study here, the REFER meta-analysis. So this was throughout Austria, France, and Germany. They did a meta-analysis. They started to look at all of the data that was becoming available from continuous glucose monitoring and cut it slightly differently. So we've had, we know that in type 1 diabetes, just left alone, people can improve their outcomes. We know from the France study that across both type 1 and type 2 diabetes, people continued to use this technology over time and continue to reduce the amount of severe complications from hyper, hypo, etc. And so here we were looking at cutting this data slightly differently, again, looking at the population who had access to this technology and seeing that just using it at all, it reduced the HbA1c over time once people had been, and that was just after 3 to 6 months, you can see a drop in their HbA1c from the European values of 8.9% to 8%, which is a reduction of about 10 millimoles per mole. But the subgroup analysis to me is fascinating. It looked at people below and above the age of 65. Both groups of people improve their HbA1c from baseline. So this is not something that is just their technology for the younger person. We could see, again, the same drop between males and females. Duration of years of insulin, whether people had been on insulin less than 9 years or more than 9 years, made no difference. Both groups of people improve their A1C. And then this is the fascinating bit, BMI. So whether that was below 30 or above 30, and whether their baseline A1C was below 9 or above 9%. So in our money, 9% is 75 millimoles per mole. Was that below or above that? And you can see in these groups, actually, the people with a higher BMI or the poorer glycemic control actually had a significantly better reduction in A1C once they had access to this technology. So people can interpret what they're seeing and make choices, which then leads to improved glycemic control. So if we can have the next slide, please. So, I was going to say my screen has gone completely blank, so I will do this from memory, but the picture is back now. So let's think about time in range. Again, Jane mentioned this briefly, but time in range, this is the optimal glucose target that we want people to spend as much time as possible between. Now, historically, we've always said if somebody's testing, we want their glucose levels to be between 4 and 7, etc. Or a normal glucose is between 4 and 7. But the target range here, where we want people to be most of the time, is a target range between 3.9 and 10. And again, 3.9, why 3.9? What an odd number to use. But again, we've got to think this is global work, and the rest of the world tend to measure glucose in milligrams per deciliter. And 3.9 actually is 70 milligrams per deciliter. So it's just an easier number for the rest of the world. And so for us, that ideal target range is 3.9 to 10. But the time in range data that we get from continuous glucose monitoring gives us the actual percentage of time across a day that somebody spends in that range, above that range, or below that range. And that's where we can start to look at where we want somebody to be. All targets should be individualized. We all know that we give people individualized HbA1c targets. And I'm hoping after this series, you'll realize that the time in range targets and individualizing them are far easier to interpret and use for people. So we have particular targets for the vast majority of people with type 1 and type 2 diabetes. And then we know that we want slightly more relaxed targets for any frail, vulnerable, or people at high risk of hypoglycemia. And then there are even more stringent targets for pregnancy. So in pregnancy, that target range is actually 3.5 to 7.8. So in pregnancy, we are trying to run people's glucose at a level as if they didn't have diabetes to get the optimum output from that pregnancy. So next slide, please. So how does that correlate? We're talking about time and range. This is new terminology to us, but what does that mean? Because everything we do and everything we are measured on is based on HbA1c. And that's because all of the evidence base for now has used HbA1c as a surrogate marker of whether we have improved things or not. So all of our evidence base, therefore all of our measurements are still based on HbA1c. But loads of work has been done looking at the data that we get from CGM and this time and range, and how does it respond to an HbA1c? Well, we can see that there is an absolute inverse correlation. What does that mean? That means that the more time you spend in range, the lower your HbA1c is. So we already have an idea that we need to get people to a certain range of time, percentage of time spent in that range to improve their HbA1c. So you can see here from the picture on the right, the higher the time in range, the lower the HbA1c. What does that look like? Well, lots of analysis has been done there. And you can see from that graph that it is pretty variable. There is no one number of if you spend X percent of time here, your HbA1c will be. There is still a range, because if you spend 70% of the time in range, we still don't know how much of the rest of that time is spent higher or lower. So there's going to be a range in HbA1c. However, the best correlation that we get is if you spend 70% of your time with a glucose between 3.9 and 10, your HbA1c will be somewhere between 50 and 53 millimoles per mole, depending on how you look at that. The more time in range you spend, if you see here 90% time in range, your HbA1c could be somewhere between 32 and 42. And then coming down the other end, if you spend 20% of your time in that glucose range of 3.9 to 10, your HbA1c will be somewhere between 80 and 90. So we absolutely can tell where somebody's time in range is as to roughly what HbA1c they're going to get. So and in fact, Vigurthi, when he did his analysis here, suggested that at the end of this, that time in range should start to become a surrogate marker when we are doing research, when new therapies come online, when new treatments come online, that we should be using time in range as our marker, because actually we will be moving now towards time in range above HbA1c because it gives us so much more information. So that's why we are trending towards this technology. And the next slide, please. So what does that mean? So we've always known HbA1c, the better the HbA1c, the greater risk reduction there is of the complications. And exactly the same data comes from this. So for every 10% increase in time and range, of which you'll get about a 1% HbA1c reduction, 10 millimoles per mole, you will see a reduction in the risk of long-term complications, primarily diabetes, heart-related complications, kidney disease, eye disease, but by quite staggering amounts. So we can work with people to increase the amount, the percentage of time that they can spend in that range, and we know it's having a clinically significant outcome. And to increase their time in range by 10%, that's spending an extra 2.5 hours a day in that range of 3.9 to 10. So it doesn't take huge differences in where we're managing their control to see that we can get that improved time in range. And so the next slide, please. And this is where our ranges come. So for the vast majority of people, children, young adults, people with type 1 and type 2 diabetes, on the whole, we are aiming for them to have an A1C of about 53. And that's why our target range is to be at least 70% of the time in the green there, in that target range of 3.9 to 10. But for a lot of people, particularly in primary care, that can be too tight a range. So our older, frailer, more vulnerable people with a high risk of hypoglycemia, we don't want them running that tight. So if I can have the next slide, please. We can see that for this older age group, we're doing two things. We only want them in that target range about 50% of the time, with a lot of time spent between 10 and 14. But there is an absolute priority to avoid hypoglycemia. So you can see here, for this group of people, the priority is to reduce the risk of hypoglycemia, and we want people to be spending less than 1% of their time in hypo. So again, you know that when we're looking at this group of people, most of the time we would want their blood glucose levels to run between 8 and 15, and this consensus time in range allows us to do exactly what we've done. We just see the data differently. So with that, I'm going to welcome back Jane and Sarah to see if we have lots of questions to answer.
Thank you, Sue. Yeah. That was fantastic. I covered loads of information, but I gave a real kind of good overview, both of you, I think, on what the device is and just the very kind of start of some of these terms, time in range and so on. So we're starting to get some questions in, which is great. So do send your questions in, folks. Got sort of 12, 13 minutes or so, I think, to do a few questions. So keep them coming in. I've obviously got some in reserve anyway myself. So let's go from the top, I think, if we may. I think I'm going to do this one for Jane, because I think you did sort of cover this, Jane, but I think maybe it's worth mentioning again, because things have changed a little bit recently. So attendees saying, can I ask if I've got this correct? The difference between real-time CGM, RT CGM, and intermittently scanned IS CGM is simply the needing to scan the sensor or not. Have they got that correct, Jane?
Absolutely correct. Yes, absolutely. I mean, it's probably been about would it be about 14 months, I think. Is that right, Sue, that we've had that facility with using a mobile device, that you don't have to do the scanning. The only thing I would point out is you do need to keep the Bluetooth. We'll cover this in subsequent webinars. But the thing you need to be aware of there is tell the person to keep their Bluetooth on, switched on, because sometimes people want us to turn that off because they think it drains their kind of battery and everything. So they do need to keep Bluetooth switched on. And as I said, they obviously need to be within kind of range. So probably about 6 meters, 20 feet, something like that. Yeah.
Yeah,
but
no, lovely.
It will retrieve the data. So if somebody, had it does backfill, if you like, 8 hours worth of data. So if the other thing, of course, we'll talk more about this, is signal loss. So sometimes it's a good idea for a person to have the alarm for signal loss switched on, so that if they were to move away from the device that they're using, then that would be picked up.
Fabulous, thank you, Jane. There's questions coming in thick and fast now. I knew this would happen, so I'm gonna keep pushing through them as we get through as many as we can. I think to Sue, do you think this technology will eventually be made available to everybody with type 2 diabetes on insulin, rather than those just on multiple daily injections? Now, Sue, you and I will cover more of this next week, I think, won't we? Because we're going to talk about identifying suitable patients next week. But just give us a little overview of your thoughts on, is this going to become the norm for everyone on insulin?
Yeah, I absolutely think it is, and possibly beyond insulin use. And if you lived in Wales, then it would be beyond that now, wouldn't it, Sarah? This is in Wales, you can have access to this for anybody on insulin. The reason, and when you say multiple daily injections, actually the NICE criteria, that constitutes 2 or more injections a day. So we're not looking at people just on 4 injections a day. We will cover this much more. But yes, absolutely, this will become the only method of glucose monitoring in the future, long after I've gone, Sarah, but still probably within your working life.
Don't say that, Sue. We couldn't possibly imagine doing this job without you ever. Certainly not. But quite a few questions coming in on that note, actually. So, you know, people say it would be amazing to let more people with type 2 diabetes have this technology eventually. Yes, I agree. And the criteria, another question about criteria here is that people with type 2 diabetes need to be on multiple daily injections, not just basal insulin. Like I say, we'll go into it more next week, won't we, Sue? But you're right. The nice wording is 2 or more injections. Am I right?
It is. It is. I mean, it says multiple daily, but when you actually scroll down to the small print, it's 2 or more. So you might want to split that basal.
Indeed.
I suppose in a way, when you think about it, with type 1 diabetes, it's been a journey, hasn't it? If you go back, well, actually, the tech's been around for 10 years, hasn't it?
10 years.
So, you know, it's been a journey because to begin with, there were difficulties. I even remember having a struggle to get some of my people with type 1 diabetes, this sort of tech. So,
yeah, we were limited to 20% of our population. And that's because of cost. And we have to appreciate, we have to bring this. And when I said, you know, I've never seen technology move so fast, it's because the data was overwhelming. Once we started to use this, once this was in the hands of people, and let's remember, this was sold directly to people long before it went on drug tariff. People managed to improve their diabetes long before we got involved with them because the data made sense to them. Our role now is to help people get the best out of it.
It's interesting you talked about age, Sue, because it just occurred to me when you said not just for the young, and that really resonated with me because I've had some, you know, much older people, you know, late 70s, 80, who have really embraced the technology, which has been, you know, probably quite a learning thing for me to realise that.
Yeah, no, likewise. My favourite patient is a 96-year-old chap.
Fantastic.
You know, it's transformed his life. And it's interesting you're saying, Sue, about, you know, people have been buying it beforehand anyway. And for me, I suppose what I find in my own experience is that actually just giving people this technology, they go off and they make a lot of changes themselves because they suddenly get their diabetes, which is amazing to see. And people come back and say, do you know, if I go for a walk after lunch, actually my glucose comes down. I was like, and so I'm going for a walk every day. And I was like, yeah. You know, it's brilliant. I love seeing
We've
that.
been telling them, yeah. And I think there was another question that's come in when I said something about BMI, and
Yes,
that's
go on.
that. So I think what the data is trying to say is that, you know, we make assumptions about whether people will use this data or not. But actually, in the way that they cut that data, the way they looked at it, people with the greater the BMI, the better reduction they had, probably because there were more things that they could change. So we don't quite know what it was, but actually the older people were, the higher their A1C was, the greater the reduction you saw, because there are more things to change and interpret and learn from the data. That's what I think it's saying. Not that we, you know, let's not reserve this just for those with a really high BMI. I think it just means this data is meaningful to people.
Yeah, that's really interesting. Thank you, Sue. I was going to pick up on that. Right, we're going to go through these questions top speed. So, does it need to be worn on the back of the arm, or can it be worn anywhere else?
So with this system, it's back of the arm. With other systems, it just depends on where they were trialed. And with this system, it was only trialed on the arm.
Thank you, ladies. Sue, can you just go back over the recommended acceptable percentage for time in range for most people, time below range and time above range? I know we will, again, go into more detail in the subsequent webinars.
Okay, so it's for most people, if you want to achieve an A1C of about 53, you're looking at least 70% of the time in that glucose range of 3.9 to 10, with less than 5% spent below that. And then you've got 2 ranges above, but we will explore this more in subsequent webinars.
Lovely, thank you. But people just getting used to those terms, which I think is great, isn't it? So time in range, time below range, time above range. Some more abbreviations for us to learn, maybe. This is an interesting question. So how does intermittently scan? So say so we know that not FreeStyle Libre 2 now, it does not need to be scanned if we're using a phone, but if someone's using a reader, they do still need to scan. So the question is, if someone is scanning with a reader, how does that deliver alarms for hypoglycemia, for example, in real time? Who would like to take that?
Well, go on, Sue.
Well, the challenge there is if it's scanning, it's not going to. So that's why we're trying to move people towards. And Do you know what, when you actually work with people, so the scanners can't alarm, basically, the reader. The reader can't alarm. The alarms come when it's on an app in a phone. And I just try and work with people to find, and you know, although we say an up-to-date compatible phone, they're not actually, you know, state-of-the-art phones. These are, you know, these can be quite, and usually when you talk to people, somebody in the family has a phone of that sort of spec that they're no longer using. People don't keep phones, apart from my mother did, I have to say. You don't keep a phone forever and a day. The phone that we found after she'd gone was quite remarkable. But most people do change them. So there's usually somebody around that would have a phone with a high enough spec to take this. It doesn't have to be that challenging. But you know, the one thing we do have to make sure is that, you know, there will be areas of deprivation, and we cannot exclude. We have to come up with innovative ways of making sure that the most people can get access to this technology.
Absolutely. A couple more I think we've got time for. Thank you. So this is one about the app when people are using a phone. Patients report to me that when they update their phones, they can struggle with using the app at that stage. Any tips? Now, I know that when FreeStyle Libre 2 moved from intermittently scanning to continuous, there was a little update needed to the app at that stage, and there was a little sort of delay in that sometimes occurring. People just need to make sure that they've got the most up-to-date version. Am I right?
Yeah, that absolutely they do. And do you know what? If there's any issues at all, you just go online to Abbott, because there is always help and support there with making sure that these apps are working.
Yes, I must say I found the tech support line very helpful. So rather than patients contacting us in the surgery, we encourage actually the non-clinical staff, even on the reception desk, to signpost patients towards the tech helpline.
Absolutely.
Great, thank you. But it's going to be Sue again, but I'm going to come to Jane afterwards. Oh yes, I will come to Jane afterwards. But yeah, one more for Sue, one more for Jane. I think we've got time for. Thank you. Sue, sorry. Is there any recommended limit of glucose variability in a day? Now, glucose variability is a new concept to a lot of us, I think. But how do we measure that variability? And is there a sort of limit to that variability that we want to see?
Yeah, we want to see less than 36% variability across the day. There you go, simple answer. But we will discuss this far more. But that's what you're looking for. 36% is the magic number.
You see, whenever I do anything with Sue, I always learn something, and that's a new magic number to me. So yeah, we are going to learn lots more together on these courses, folks. That's for sure. Jane, around that slight difference in the lag between the capillary glucose monitor and the interstitial fluid that we get from the CGM. Someone's asking, do we need to do capillary testing in situations where there is rapidly lowering or rapidly changing glucose levels because of that slight lag?
Yeah, I would say yes. So you don't want to stop the prescription for capillary strips, but reduce them, because, you know, people may have been using, you know, 2 boxes a month, something like that. So definitely reduce it so that people can access them, because that is exactly the situation where they may need to check. And what I also say to people is, if they are getting signs and symptoms that don't match what they're seeing on their device, then that might be a reason to check as well. You've got to still go with the signs and symptoms that you're experiencing, I would say.
Yeah, absolutely. No, that's great advice. Thank you. Okay, we're going to squeeze in another quick one. One more, just for you, if I may, Sue. Do the sensors need calibrating?
No, they're factory calibrated, so they're calibrated already. Other systems may need calibration, some have in the past, but not these at all.
Fantastic. There's more questions coming. We haven't got time for all of them today, but come to the next webinar and we'll make sure we get to as many as we possibly can. Over to you, Hope.
Thank you so much, Sarah, Sue and Jane. That was absolutely brilliant. And yes, as Sarah just said, join us for the next webinar. We've got 3 more over the next 3 weeks. So use the link in the chat box and sign up for all of them. Even if you're not able to attend live, you'll get sent the recordings after they've taken place, so you can always catch up as well, and they're useful to have.